hemodialysis, and this class is for the BSc nursing second year students. We have already discussed this topic in the class, and this is a revision class for all of you. So in the previous session we discussed about what is dialysis and what is peritoneal dialysis. In this session we will discuss about the hemodialysis and the nursing responsibilities which are related with the hemodialysis. So what is hemodialysis? It is a process of removing the accumulated waste products and the water from the blood by using an artificial kidney. So in the hemodialysis, the waste products and the excess amount is removed from the blood, and by using a machine, dialysis machine, and uh, it is different from the peritoneal dialysis in the sense that in the peritoneal dialysis a peritoneal membrane is used, while in the hemodialysis a dialyzer is used, which is usually made up of cellulose, and it is in contact with the patient's blood. That's why it is called hemodialysis. Now, why hemodialysis can't be performed? In which cases the hemodialysis can't be performed? First, if there is a lack of vascular access, means that there is no any vascular access, so that we can make fistula graft, or we can put on the dialysis catheter for the hemodialysis. Because hemodialysis require a vascular access, it requires a fistula graft or catheter, so lack of vascular access. Then cardiovascular instability in the hemodialysis with recurrent large weight gain, fluid overload, symptomatic hypotension, and the angina. So basically, if during the hemodialysis session, because of hemodialysis only, if the person gets cardiovascular instability, for example, there is fluid overload, there is recurrent large weight gain, there is symptomatic hypotension, or the person complains of chest pain during the hemodialysis, so in those cases the person should be contraindicated for the hemodialysis, and he should put on the peritoneal dialysis. Then third is if there is a long distance from the hemodialysis unit and person is unwillingness to tolerate for the procedure. Now there are basically 5 types of hemodialysis. These are conventional, daily, nocturnal, and the CRRT and the SLEDD. So conventional hemodialysis, it is like every alternate day, so it is performed 3 times a week and 3 to 4 hours, okay, and the person's blood is drawn out at a rate of 200 to 400 ml per minute, and the needle which is used is it is of 15, 16 or 17 gauge. Now daily hemodialysis, it is done for 2 hours 6 days a week. So it is done daily, and daily 2 hours is taken for this hemodialysis procedure, and basically this is used for those patients who do their own hemodialysis at the home. It is less stressful, more gentle, but require more frequent access because we are performing it daily, so there is requirement of vascular access frequently. This is simple with the catheters but more problematic with the fistula or the graft. Obviously, if there is a catheter, so daily hemodialysis is easy, but if there is no any access of the catheter, it is problem if there is a fistula or the graft. So if we want to have a frequent vascular access, or if daily hemodialysis is used, then in the fistula we use the buttonhole technique. What is it? Here you can see buttonhole cannulation technique. In this, very dull needles are used, not the sharp pointed needles, and every time they will be placed, these needles will be placed in the exact same hole. So because we are doing the daily hemodialysis and we are putting or placing the needles in the exact same hole in the fistula, so there will be a creation of a tunnel track for the needle. So there a track will be formed, a track will be produced, and every time the needle will be inserted in this track. So this will prevent the case of the aneurysm. So that's why buttonhole cannulation technique is used in the cases of fistula and the graft. Then nocturnal hemodialysis, as the name is suggesting, it is performed during the night, during when the person sleeps. So it is similar to the conventional. It has similar properties as the conventional hemodialysis, but it is performed 3 to 6 nights a week and between 6 and 10 hours per session when the patient sleeps. Then continuous renal replacement therapy, it is done 24 hours a day, and it is usually done if the person is hemodynamically unstable. So it is done very slowly and it is done 24 hours a day, so the chances of instability of the hemodynamic parameters reduces. That's why it is done 24 hours a day. Now, what are the advantages of this CRRT? Basically, it is used in hemodynamically unstable patients who are unable to regulate their blood pressure, who are highly sensitive to the fluid changes at the weight gain, than if they are highly sensitive for the infection or the shock. It also facilitates gradual correction of the biochemical abnormalities. So there will be gradual correction of the electrolyte imbalances. It is highly effective to remove the large amount of fluid over few hours. So basically 20 liter of fluid approximately removed over the few hours. Now, what are the contraindications? The contraindications are CRRT is never performed if there are life-threatening manifestations of the uremia. That is, if the person is having hyperkalemia, pericarditis, in those cases CRRT is avoided. Now SLEDD, we can write it as a SLED also or SLEDD also. So it is slow or the sustained low efficiency daily dialysis or slow or sustained low efficiency dialysis. So basically it is performed in critically ill patients who are having the hyperkalemia also. It is not as the CRRT, and it is basically in between the intermittent hemodialysis and the CRRT. So it is a in medium of that. It is done 6 to 12 hours daily. The blood flow rate is the 100 to 150 ml per minute, and the dialysate flow rate is the 100 to 200 ml per minute or 6 to 12 hours per liter. So this is about the SLEDD, which is used most commonly nowadays. Now, what are the vascular access for the hemodialysis? There are three. First one is fistula, second one is graft, and third is catheters, which are known as temporary vascular access. AV means arteriovenous, means there is a creation or there is a link of the artery and the vein. Now this is a catheter. In this, these are called dialysis catheter. There are two lumens. One is arterial and the second one is venous. The most commonly the red one is for the arterial and the blue one is for the venous. And the red arterial lumen, it will withdraw the blood from the patient and then it will carry it to the dialysis machine. From the dialysis machine, it will carry to the patient through this blue, which is the venous lumen. So basically where it is inserted, the dialysis catheter is inserted into the vena cava and via the internal jugular vein or the femoral vein. There are two types of catheter we can use. It can be tunneled and the non-tunneled. You can see here in the tunneled, the some part of the catheter it is under the skin, while in the non-tunneled there is no any tunnel is made. The catheter is directly placed at the site only, so there is no any part of the catheter which is under the skin. So tunnel catheter involves a longer catheter, and these are tunneled under the skin from the point of insertion in the vein to an exit site some distance away. Basically, these are placed in the internal jugular vein in the neck, and the exit site is usually on the chest wall. Then tunnel catheter, the tunnel acts as a barrier to invade the microbes, and basically we are creating a tunnel so that the infection chances can be reduced, and it is done for the week to month. We can use this tunnel catheter for weeks to month. But in the non-tunnel catheter, it is used only for up to 10 days and maybe one dialysis session only. So the catheter emerges from the skin at the site of entry only. Now fistulas, there is the anastomosis or the joining of the artery and the vein, and because we are joining the artery and the vein, the blood flow from the artery to the vein, from the blood flow will divert from the artery to the vein. So the because of increased pressure in the vein, it will increase in size. It will develop thicker walls. So vein will be of similar size like the artery. Its walls will become thicker. So how much time fistula take to mature? It may basically takes 6 weeks to month. Now, for checking the patency of this fistula, there is the palpation method and the auscultation method. If you are palpating the fistula site, you will feel for the thrill, which is the vibrating sensation because of the blood flow towards this fistula. So this is a thrill which is buzzing, and it is palpated at the area of the fistula. While if the person is auscultating the site of the fistula, there will be bruit. There will be rushing sound because of the increased increased or high pressure blood flow towards this fistula. We have already discussed about the buttonhole technique. Now, AV fistula, it is the anastomosis of the artery and the vein, which can be shown in this figure. Similarly, here the artery is connected to the vein and the blood get mixed. Vein is expanded because of the increased blood pressure. Now, what are the common fistula sites, right? We can anastomose these artery and vein by side of artery to the side of vein, then side of artery to the end of vein, or we can use the end of artery to the side of vein, or end to end, means end of artery to the end of vein. So these are basically the common method of anastomosis in which we can use the side of the blood vessel or the end of the blood vessel. Now, we can use radial artery and the cephalic vein for the fistula making. We can use the brachial artery and the cephalic vein for the fistula. We can use the brachial artery and the basilic vein. And we can use the radial artery and the cephalic vein. So these are the common arteries and the veins which are basically used for the AV fistula. Now, how to care about this fistula? As you all of know, avoid checking the BP also, doing the venipuncture, taking blood samples, or giving injection at that hand. Giving IV drug or slipping on that arm should be avoided. You can also place a armband on the patient's hand and indicating that there should be no any BP measurement, venipuncture or injection on that side, or we can place a sign over the bed also. Then check the thrill at least once daily. You have to check for the thrill. Avoid the tight clothing, jewelry or watch in that hand. Avoid carrying heavy object with that hand. Avoid exposure to excessive heat or the cold. Now, before you are assessing or touching the vascular access, perform the hand hygiene and position the patient arm so that the fistula is easily visualized. After dialysis, assess the fistula for any bleeding or hemorrhage. Check the patient circulation, means check for the thrill. Also observe the capillary refill in the fingers. Assess for the numbness, tingling, alter sensation, coldness or the pallor in the affected extremity. Then assess the vascular access for sign of infection also. So for the infection, you have to look for the redness, any warmth, any tenderness, any purulent discharge, open sore or the swelling. So because of the frequent access of this fistula, the aneurysm develops, which can be shown here. The image is showing the aneurysm. Now, graft. In the fistula, we were using the original blood vessel, right? But in case if there is no any availability of this original blood vessel, we will use a artificial vessel. So if you are using the artificial vessel to join this artery and the vein, then it is the AV graft. So the graft is usually made of a synthetic material which is called as PTFE, polytetrafluoroethylene, which is also known as Teflon. And basically the AV graft required less time than the AV fistula. AV fistula requires 6 weeks to month, but graft required just only 2 to 4 weeks. But there are more complications here because it is an artificial vessel, so there are more chances of getting the blood clot. So that's why the risk of the thrombosis is more and the infection is more in the AV graft. So in this diagram you can see there are two grafts, straight graft and the loop graft. Between the radial and the cubital vein, a artificial vessel is used which is straight. So that's why it is called straight graft. But in the loop graft, the brachial artery and the cubital vein are joined by an artificial vessel, and this vessel is in the shape of a loop. That's why it is called loop graft. Now, what about the hemodialysis machine, right? In the hemodialysis machine, you can see the person from the person's body, the blood is removed, then it goes through the arterial pressure monitor in which a specific pressure is maintained, then it is go through the blood pump, and this blood pump, it has a main function of ensuring that blood goes in a followed up direction in the um, forward direction, so that it does not clot. So from the blood pump, it is going through the heparin pump. In this, a syringe is injected with the syringe is filled with the heparin solution, and this heparin is administered at a particular rate so that blood can't be clot. From this heparin, there is the inflow pressure monitor, then there is a dialysate. So the blood is removed from the body, then it is going into the dialyser. In the dialyser, there is the fresh dialysate, and there are two dialysate here. There are two chambers here. One chamber is the fresh dialysate, and second is the used dialysate. So this fresh dialysate will be used by this dialyser, and the blood which is removed from the body will be coming into this dialyser, then it will be filtered out, and the removed product will be come and accumulated in this used dialysate only. Okay, then from there the blood is removed, it is cleaned, it is filtered, then it will go to the venous pressure monitor. There is the air trapped and air detector, so that air embolism can be prevented, and then this clean blood will come back to the body. So this is the basic diagram of a hemodialysis machine. In practical, you will see the hemodialysis machine looks like this, in which there is the display which shows everything. What is the flow rate, how much fluid is removed, what is the blood pressure of the person, what is the heart rate, then what is the ultrafiltration rate. Then there are pressure flow monitors also. Then there is a dialysate also. There is the um, dialysate also. There is the heparin blood pump also. There is the injection of heparin also. There is the dialysate also. So already what we have discussed, this is in this diagram only. Now in this dialyser, it is made up of cellulose, right? And it is in the form of fibers. So there are various fibers, and these are made up of cellulose, and these are very thin, and they help and they act as a semi permeable membrane, and therefore lead to the filtration of the waste products. Then dialyser, this is a plastic cartridge. It contains thousands of fibers. These fibers are semi permeable membrane. These are made up of cellulose or the synthetic material, that is polyaryl arylithosulfane, polyamide, polyvinyl, pyrrolidine, polycarbonate, and the polyacrylene nitrile. So, but the dialyser is different in the surface area, membrane composition, thickness. Uh, so, it basically, for a one person, if the person is coming for the conventional hemodialysis, means every alternate day the person is coming to the hemodialysis machine, a dialyser is fixed for that person, and same dialyser will be used for that person. So basically one dialyser is most commonly used for approximately 3 sessions. So it is because it is different, and also the chances of getting the infections, getting the bloodborne infections, getting the HIV, hepatitis B, C, this will be reduced. So that's why same dialyser is used, which can be reused for 2 more sessions. Now we discussed about the dialysate solution. There are two parts of the dialysate solution, part A and the part B. In the part A, we put the sodium chloride, potassium chloride, magnesium chloride, and the glucose monohydrate. In the part B, there is a hydrogen carbonate powder, and it is dissolved in the water. And in the part B, there is sodium chloride and the hydrocarbonate. Now, what are the complications of hemodialysis? The complications of hemodialysis: first, fluid shift. It means if we have not set the rate appropriately, it may be that the excessive fluid is removed very rapidly, or there may be chances that the person may get hypotensive, because the fluid is removed at a very uh, at a very um, fast rate, so there may be hypotension. Also, the person, those kidney failure patients are having hypertension. So before doing the hemodialysis, we generally check their blood pressure, and if it is hypertensive, so we generally give the medication, so that the antihypertensive medications we give, so that the blood pressure get normalized, and after that we perform the hemodialysis. Because there may be chances of uh, hemodynamic instability during the procedure. Then SS related, it can be like that, because during the procedure the fistula, the graft site get infected. There may be infection at the site, or there may be chances of air embolism. There may be pyogenic infection at the site. Then anticoagulation related, generally we have seen in the clinical postings that if the amount of heparin is more, then the person may bleed. Because of this heparin, the person may bleed, the person may have oral bleed, the person may have rectal bleed, the person may have hematuria. So the concentration of heparin, how much it needs to be put it on the hemodialysis machine, is very important. Then first use syndrome, uh, it is basically first time the person is getting the hemodialysis, and it is basically a severe anaphylactic reaction. And because it is because of the material, the cellulose which is used in the dialyzer. So the person is allergic to this cellulose, or the material which is made up of this, which is making this dialyzer. Then cardiovascular instability and the electrolyte imbalances may occur during the hemodialysis session. What are the common drugs which are used after dialysis? Basically, optineuron is given, and the erythropoietin is given after the dialysis or during dialysis also. Now, what are the nursing responsibilities which are related with the hemodialysis? Prepare the patient emotionally and physically. Take the informed consent, weigh the patient, check the laboratory values like KFT and the viral markers. In the KFT, you will check for the blood urea, serum creatinine, ammonia, then your electrolyte levels like sodium, potassium, calcium, magnesium, phosphate. Viral markers, HIV, hepatitis B, C. Check the vital signs of the patient, especially the pulse rate and the blood pressure. Then assess the mental status, respiratory and the cardiovascular assess status, so that the complications can be prevented. Before dialysis, instruct patient to empty the bladder, check the catheter site, document all the findings properly. Then prepare the dialysis machine by using proper setting, rinsing and priming. During dialysis, maintain aseptic technique. When you are connecting the dialyzer to the patient vascular access, whether it is a catheter, whether it is a fistula or the graft, maintain aseptic technique. Observation of the patient include vital signs should be checked every hourly for the 3 to 4 hours, and then half hourly. Then observe for the cardiac rhythm, teaching, headache and the pruritus, which may show the complications. Watch the machine. There must not be any sudden break in the circuit. There should not be any kinking, so that venous pressure may get high. There may not be low venous pressure, low arterial pressure, or the blood pump may fail. Watch the machine for any discrepancy. Then also watch for the disequilibrium syndrome, hypersensitivity reaction, seizure, air embolism. Basically, in the disequilibrium syndrome, as you all know, the ammonia can pass through the blood-brain barrier. So the rate at which the urea, these nitrogenous wastes are removed from the blood, that rate is very high as in comparison to the brain level. So from the CSF, these nitrogenous wastes are not removed in the same rate as they are removed from the blood. So in that cases, the person may have cerebral edema. So the person may show the sign of confusion, mental confusion, headache, restlessness, or may the person may go into coma. So watch for that. Carefully terminate the dialysis. After the dialysis, check the vital signs, weigh the patient also, document the procedure also, document all findings also. The findings include when the dialysis was started, when it was stopped, was there any medication which was given during the dialysis, whether any complications arises during the dialysis or not. Then what was the uh, every hourly it is checked, the vital signs are checked every 15 hourly for the first hour, and then every hourly for the next hours. So the vital signs are written, the way of the patient is written, the lab documentary is done. So all these needs to be documented. Look for the complications like hypotension, hypoglycemia, bleeding, or EKG changes. Then educate the patient about the dietary management in the restriction of protein, sodium, potassium, and the fluid intake as prescribed by the doctor. So thank you so much, and today we discussed about the hemodialysis, in which we discuss what is the definition of hemodialysis, in which cases it is contraindicated, and what is the procedure of hemodialysis. Then we discussed about the what are the vascular access of the hemodialysis, dialysis machine, what are the complications, and what are the nursing responsibilities of a patient for the hemodialysis. So thank you so much. This is all for today's session.